everyone. Welcome to today's seminar on advancing value-based care in community health centers. I am Rachel Werner. I'm the Executive Director of Penn's Leonard Davis Institute. We are joined today by a great group of panelists. First, Michael Curry is the President and CEO of the Massachusetts League of Community Health Centers. Leighton Koo is Professor and Director of the Center for Health Policy Research at the George Washington University Milken Institute School of Public Health. Amanda Pierce-Kelly is the CEO of Advocates for Community Health and the Executive Director of the Association of Clinicians for the Underserved. And our moderator today is Paula Chatterjee. She is the Director of Health Equity Research here at the Leonard Davis Institute and is an Assistant Professor of Medicine at Penn. Paula, I will turn it over to you, and I'm looking forward to the conversation. Thanks.
Thank you so much, Rachel. I'm so excited to be a part of this conversation today, which I think is going to be really exciting and interesting and timely and touch on a lot of really salient policy issues. And so thank you so much to our panelists for being here. I'm just going to start by giving just some brief framing remarks for our conversation today before I punt this conversation over to you all who we really want to hear from. So I just want to start by sort of setting the stage for community health centers and value-based payment broadly. What we know is that community health centers in the United States provide really essential healthcare and social services for low-income, uninsured, and underinsured people in the United States. And really in serving this critical bedrock function of the healthcare safety net, these health centers also have to face substantial financial challenges because so much of the care that they provide is often uncompensated. And so these health centers must face these financial challenges while also serving their mission, which is really to care for patient populations who are at disproportionate risk for poor health outcomes. And that is, of course, because of the burden of the social determinants of health that these patients are experiencing. So this is really the broader context that health centers have been grappling with really since their inception. Over the past few decades, we know that value-based payment has really emerged as a strategy to try and promote high-value care across the healthcare continuum in the United States. And really the goal is to try to improve quality while containing costs. And so while value-based payment, or VBP, can take a lot of different forms. For our conversation today, we're going to refer to VBP pretty broadly as basically any type of payment approach that links performance on quality to payment. Health centers, specifically federally qualified health centers, which is going to be the focus of our conversation today, haven't been immune to the expansion of VBP among both public and private payers. But it's not clear whether these VBP efforts are really achieving their intended goals in the health center context, namely to improve quality and contain costs. And I think understanding this is really important given the unique financial challenges that health centers face, the multidimensional needs of the patients that they serve, and again, their critical role in the healthcare safety net. So over the next hour, we're really going to dive into this world of value-based payment in federally qualified health centers to try and understand what's worked, what's not worked, and how can we move forward. And so before we get into sort of the nitty-gritty of value-based payment, I'm going to ask Michael first, if you wouldn't mind giving us a little bit of sort of community health center financing 101. It would be helpful to get just like a brief overview of how our health centers paid historically, sort of under this quote unquote prospective payment system. How has it worked? How has it not worked? We know that some states are experimenting with like other alternative models. Just your financing 101, I think would be incredibly helpful to sort of level set for us here.
Well, thank you, Paula, and glad to be here with Amanda, my good friend Amanda, and Leighton. I'm not sure there is a 101 for this complex system reimbursement, but I'll try to do that. In 2000, Congress passed and the president signed in December, I believe, of 2000, the Benefits Improvement and Protection Act. And Paula, you asked that we not use acronyms. We often refer to it as BIPA, but I think if you tested people on what BIPA stood for, they might not remember. It stands for Benefits Improvement and Protection Act. It increased Medicare payments to providers, managed care organizations. It reduced certain co-pays for beneficiaries, and it improved coverage for prevention services and many other things. People may not recall that the actual title of that law was Medicare, Medicaid, and S-CHIP Benefits Improvement and Protection Act of 2000. It also addressed health center reimbursement under Medicaid, which is the critical part for this conversation today. Since 2001, federal law requires state Medicaid programs to pay federally qualified health centers for FQHCs according to a statutorily defined payment methodology, which we now call FQHC Prospective Payment System, or PPS is the method. Under FQHC PPS method, a per visit reimbursement rate is established for each individual FQHC. I want to stress that as we did a lot of work here in Massachusetts to educate our policymakers, our regulators here. It is a per visit reimbursement rate that is established for each individual FQHC. PPS rates are developed using the cost of providing the FQHC's distinct suite of services, including enabling services, and are adjusted every year by the Medicare Economic Index. And whenever the FQHC has a change in the type, intensity, duration, this is a quote, type, intensity, duration, and or amount of the services it provides. Those are actual language that we'll operate off of, called the change in scope mechanism or process. The state is allowed to implement an alternative payment method, and many states will opt to have an APM, an alternative payment method, that should pay no less than PPS as long as each individual FQHC agrees to it. That's another critical point for the conversation today. If you agree to an APM, every individual health center has to independently agree to it. So just quickly, the benefits, FQHCs were able to achieve a degree of financial stability that would otherwise not have been possible to attain, given their payer mix and the large number of uninsured patients that we served. HRSA 330 grants should not and were not intended to be used to subsidize Medicaid underpayment, which was historically the case. Where it falls short, PPS rates are more cost related, and I was discussing this with my staff this week, the distinction. PPS rates are more cost related than truly cost based, and thus often fall short of actual true costs. For example, if the cost of doing business exceeds the annual inflationary factor or the Medicare Economic Index, and services largely remain the same, no eligible change in scope to adjust the PPS rate, then the PPS rate falls short of actual true costs. So many states have failed to fully implement the PPS methodology to the full extent outlined in the federal statute, undermining its thoughtful design and intent and denying FQHCs needed financial support. We'll talk later about what we did in Massachusetts to really tee up a rate change here in Medicaid, underlying or based off of all the things I just presented.
That's extremely helpful. I certainly have been trying to read about very complicated financing mechanisms. And thank you so much for sort of explaining PPS, this per visit reimbursement strategy, and sort of where alternative payment models can come in from the state side of things. And then I think this difference that you highlight about sort of cost related versus cost based reimbursement is a really interesting one that I might want to just pull at that thread a little bit and tie it to our next question, which is, can you tell us a little bit about sort of like how that cost based versus cost related approach can sometimes potentially fall short or be advantageous? And then I know that health centers are sort of paid by multiple different payers, whether it's the Medicaid program, whether it's commercial insurers, whether it's the Medicare program, and just curious whether there are shared themes across different payers or whether each of them is really sort of their own different beast.
Yeah, I'll start with the latter. So let's talk just sort of the buckets of how we get paid. So Medicare would be one. The Affordable Care Act included a statutory requirement that Medicare also pay FQHCs under a PPS methodology. However, instead of establishing an individual FQHC specific rate, the Medicare PPS methodology establishes one national base rate that's developed using aggregated FQHC cost reports, and then it then is adjusted according to the geographic location of the FQHC to reflect variation in the location's cost. So there's a more uniform way under Medicare for that PPS reimbursement. Commercial is very different. Commercial includes plans through the health insurance marketplace, as an example. They contract individually with FQHCs and pay a negotiated rate according to the contract, right? Again, critical point. stressing that it's negotiated and it's according to the contract. In Massachusetts, commercial plans tend to pay the FQHCs notably less than Medicaid and Medicare. So we're in Massachusetts, we were able to negotiate Medicare up and increase those rates, but we are now in the throes of really trying to hold the state health plans accountable to actually increase their rates. This is sort of a broader conversation, not a negotiation on the individual rates that they offer individual health centers, but just a broad theme across the state that commercial is underpaying health centers and now paying less than Medicaid. And that's part of the problem. So we say cost-based, but versus the true cost. We'll talk a little bit more in some of the conversation, Paul, about where those costs lie and what is the true cost of providing care to a patient who walks into a community health center. And when you start thinking about the unreimbursed cost, and you start thinking about the various behavioral health and other services we provide, you start to find and sort of pull at the thread that the cost isn't truly providing what we need to meet the demands and the care that we provide to patients.
Got it. So it sounds like there's a prospective payment system in place. It perhaps might not be indexed in a way that actually reflects the cost of the visit. Sometimes, states can choose to do these alternative payment models, and those are sort of different depending on the place. And then overlying that complexity, it sounds like each different payer also has different approaches for how they are reimbursing health centers, what the specific rules are, and those rules even vary by visit type. Oh, yes, Amanda, please jump in.
I would just call out too that and Michael mentioned this, but I think there's wild variation from state to state. And so there are places, unfortunately, where they haven't adjusted those rates for years. And so if we think about what has gone on just through the pandemic and sort of where we are economically right now, like that is a massive impact. And then I think the other thing, just anecdotally, is that to Michael's point, most of the time, the PPS rate is not covering the true cost. So most of the time health centers are taking a hit, even though, so the value of it is that there's predictability, right? Is that they can say, okay, for these patients, we can count on this. But there are a litany of issues between that PPS rate being outdated, that PPS rate never actually really covering the true cost of all of the services being provided, which I think is what you were kind of leaning into very correctly. I would also say, the reality is, sadly, commercial insurance, while it's a smaller portion, typically they're the worst payers, and there's a variety of reasons for that. So health centers are just really challenged with, it's kind of in all corners. I think the Medicare PPS is probably the easiest. I don't know, that might be an overstatement, but the easiest because it is a bit more uniform and there is a very specific formula that goes across the board. But there's a lot of work to do in this space. And I know that's the entire point of the conversation, but I just wanted, it really is messy for a variety of reasons. So sorry to chime in.
And I want to add a little bit piece to Amanda too. So just using the Massachusetts example again, historic underpayment to Amanda's point, and then you have COVID, and then you have a migrant crisis, and of course the resources that need to be deployed for that. It really tears at the fragility, or it addresses or impacts the fragility that health centers operate in all the time. And that under reimbursement could be devastating when it comes to trying to meet the demands that states are requiring of its health centers, particularly in a pandemic where we stepped in as de facto public health departments would be an example. So payment has to be good, has to be adequate for the care we provide, or we end up hurting our overall healthcare system.
Yeah. And then sorry, we're going to end up doing this, but I'm just going to, it like keeps going.
Double
right?
Dutch, I call it.
Right. Exactly. I think the other thing that I would call out is that, and, a lot of the work for me, I'm wearing a workforce hat a lot because that's a lot of the work that we do at ACU for health centers. But the other thing that we see, Paula, is that, so we have all of the issues that we just talked about. And then you look across the sector and health centers can't adjust their rate. It's not like, oh, geez, the cost of goods is going up and the cost of labor is going up and the cost of this and that. That isn't how it works. So then if you look at that and you translate it across, okay, what does that look like from a workforce perspective? They can't adjust their salaries. They can't adjust their recruitment and retention opportunity. And so the strains that health centers are facing right now as a result of this payment system and methodology, has a ripple effect across operations, workforce, you name it. So while today I think we're very rightly focused on the payment component of this, if we can make the improvements and the adjustments that I think hopefully all of us are working toward, the impact that has is far reaching across the entire operation and the ability for them to have even greater impact. So just connecting dots there.
Thank you so much. I think that was certainly for me just a very helpful way to contextualize how complicated it is, how recent factors have really increased the strain for a variety of different reasons. And I think that lets me pull in Leighton into this conversation, which is that, Leighton, it would be so helpful to have your expertise about the context in which the typical health center functions from a financial standpoint. Sort of, can you give us a sense of how community health centers are faring financially under this really complicated patchwork system of funding?
Sure. So as Amanda and Michael have said, it is a very complicated patchwork system of funding. Nonetheless, we do have some data, though I say it's not perfect data about the financial status of health centers using something called the Uniform Data System. We've done some analysis of that, and the most recent data is for 2023, so it's a little dated. But when we go back and look at those analyses, in 2021, health centers had a positive margin of 5.3%. That's revenues minus cost. So essentially, they were in the black of around 5%. That margin has fallen sharply. So by the most recent data that we have of 2023, the margin fell to 1.6%. And when we look at health centers across the nation, about half the health centers were in the red and about half the centers were in the black. Our projection is that things are worse in 2024. What has happened is that Medicaid unwinding has occurred, so there are a lot fewer Medicaid patients bringing in revenue. During the COVID pandemic, there were extra COVID funds that the federal government and in some cases states provided to help out health centers during that crisis period. But those COVID funds have not been renewed, and so they're gradually been exhausted. The net effect is that in this year, our projection, and again, we don't have the real data, it's a smart guess, is that the average margin is minus 2.2%. And we think the majority of health centers in the country are in the red. So right now, it's a bad situation. And of course, we also know that we're coming into 2025. There's the problem. Congress has not yet given appropriations for health centers for 2025. There's a continuing resolution that ends in December. What'll happen after that is not quite clear. Given what's happened politically just in the past week, I'd say the situation looks pretty tight. I would not expect to see substantial increases in investments for this sort of core Section 330 grants, but maybe I'm wrong. I'd hope that there'll be some optimism there. But anyway, so it's looking kind of tough in that regard. Then the next thing you sort of wanted to ask about was, so what's the relationship between value-based payment systems and financial margins? Basically, given these challenges, in principle, value-based payment systems ought to help health centers if they can sort of be a little more efficient, give better quality care, and so they might help out. So let me just start off by saying there's some complications that occur with why VBP might not work completely well for health centers as compared to a typical doctor's office. It's not that it necessarily works perfectly for doctor's offices either. But so one is we have this complicated reimbursement system, the prospective payment system that Michael talked about. So it's not like health centers are paid in the same way. So that in many cases, the incentives designed by value-based payment systems are designed around regular medical practices. So that's not working quite in the way that health centers are paid in the first place. Because of that, many health centers have been reticent to go into value-based payment systems because they think it might basically hurt them. They might end up losing money as opposed to doing better on it. Some have gone forward, but this has been a problem for health centers where they're hesitant to enter in because they have this somewhat protected, imperfect system, but nonetheless, they have some guarantee under the prospective payment system. And I'll say, regardless of this, we do know that health centers provide high quality care, save money. We've done lots of research about this. The Congressional Budget Office just recently agreed, yes, patients getting care at community health centers saves Medicare and Medicaid money. It is an efficient system that saves the government money overall, which is the value, the underlying concept of value-based care. So they're already doing that. And in part, it's because HRSA, which administers that, has set up a monitoring structure all along and set up all sorts of ways, working with primary care associations and CHCs to try to sort of maintain high quality preventive ambulatory care and primary care. So the second reason why VPP is a little troublesome is there's also, as Michael and Amanda mentioned, there are like 10 to 15 funding streams coming into a typical health center. So because of their multiple Medicaid managed care systems, as well as fee for service, as well as Medicare, as well as private insurance, as well as other grants like Ryan White and Title 10 and so on and so forth. So because of that, the funding is very fragmented. So the amount of money that any VPP system can give, and they're all unique, tends to be sort of fragmented. And in addition, they all want different performance monitoring systems. So you have a lot of reporting requirements that are diverse, and then not much bang for the buck because the system is so fragmented. And the third thing I'll say, and this is a little more conceptual issue, is that most value-based payment systems are designed for regular doctor's offices. But the problem, to my mind, conceptually, is health centers aren't like doctor's offices. They provide a broader scope of services. So there is part of me that would say, if you really want a value-based system that works for health centers, then you would try to include things that health centers do, like they mostly provide behavioral health care. That's not typically part of the performance monitoring system that's set up in these systems. They provide enabling and community-based services. So they provide interpretation, they provide transportation, they provide community outreach services. These are not part of the ways that we typically monitor performances in value-based payment systems. So if that could be adapted, that could make some better sense for health centers and really let them do the things that make the real difference and why health centers are so effective. But that's not part of the way the system is defined now. So the next thing, but I can stop right now. You'd asked, do we know about what's the relationship between VPP and financial margins? And I did some very quick analyses just within the past couple of days. It's sort of the sort of the equivalent of back of the envelope stuff. I can talk about it now, or I can hold it. What's your preference?
Good question. I mean, and quite the enticing offer. Maybe we pause on it for 1 second, just because
Sure.
before we get into sort of the risk conversation, I think this idea of sort of really capturing all of the factors that make it hard for health centers to participate in these models is just important, honestly, from my understanding, and in terms of understanding the landscape in which we are trying to introduce these payment models. And so from you, Leighton, I learned that there's immense fragmentation in the healthcare in the way that they are funded and in the many incentives that they have to meet from those funders. There are different reporting needs, different scope of services. Amanda, I'd love to know if there are other barriers that are worth considering as we dive into sort of even the thought of accepting value-based payment models and assuming the upside and downside risk of that. Are there patient level factors we should be thinking about, other issues with payment, other things that we should be thinking about?
Yeah, it is worth getting a little bit further into this, and I suspect Michael and Leighton will have other things to chime in as well. But I think it's also worth sort of just thinking about, at least for ACH, sort of where we rest in this and sort of the goal of value-based care. And it's reforming existing payment systems to allow health centers to do what they do best. And we don't believe that payers, including federal payers, are the best arbiters of what that good care looks like. It's the providers that are really in the best position to do that. And so there's absolute acknowledgement that payment can drive care delivery, and we want payment to drive value. But I think part of what Leighton is getting at is that the existing metrics health centers provide, well, two things. If we look at existing metrics, health centers provide the best care in the country, and they manage chronic disease. They're providing high rates of preventive services. They're ensuring access to high value medicines. These are the things that we know. We're not interested in payment models that result in value to third parties, I think is another biggie as we're having this bigger conversation. It really needs to be about returning that value to the patients and the providers serving them. And then I think the other thing that I would just call out is that what we want from value-based care is the flexibility and the support to fully deploy and all of those proven models. It's high touch, it's interdisciplinary, it's patient-centered care, and it's got that proven success. But I think if we really lean into, okay, so what are the models that we see the greatest flexibility, and where do we run into barriers? Number one would be upfront capital to invest in sophisticated infrastructure. So in order to do this, there's a cost. And a lot of successful ACOs like data analysis tools to project financial models and integrate with EHRs. There's a lot of cost to that. And health centers, partly based on all the things that we're talking about, like the national average for health center in terms of margins is like 1% to 2%. Most of them, unfortunately, right now are operating in the red. So it's not like there's dollars laying around to go and acquire the things necessary to sort of be able to produce on these things. So that upfront capital for investment is difficult. I think access to total cost of care information is also a challenge. So a lot of health centers have limited information about what other services their patients are seeking or using outside of their four walls. And that plays a big role in sort of the bigger picture. And then I think the other thing that we see and sort of need to do more to acknowledge is that there's human capital to drive care coordination, like specifically CHWs that come to my mind, and care coordinators, and they're not billable. So I think the model also sort of forgets that piece of it. So those are the barriers. I think you want to move in, Paula, to the successful side, but I will pause there in case Michael or Leighton have other things that they would add in.
Leighton, I would love your findings on sort of where the math seems to be ending up on this back of the envelope sort of approach as we think about, what makes it hard for these health centers to be participating in these models in the first place.
So once again, I use these data called the Uniform Data System data. And there's a little measure in there about some finances. And there's a measure of how much of health centers earn from pay-for-performance systems or things like bonuses and so on and so forth in Medicaid. And so that's an indicator of the extent to which health centers are in some sort of a value-based payment system or not. When you look at that measure, about 2/5 of the health centers in the country report that they're receiving value-based care. It's about 42% in 2023. But oddly enough, this has not changed between 2020 and 2023. It's been flat at that same level. So it's not as though this has been growing or shrinking. When I look at the distribution across the states, some states have none, some states have a fair amount, but typically speaking, it's around a little less than half get some of that money. Again, some states it's more, some states it's less. Now then, when I look at how much is that value-based care payment system, in general, the value-based payments that they're earning on average across all the health centers average about 3% of their Medicaid revenue. When we only look at the ones that get a VBP system, the median amount of the performance payments is 4 to 5% of their Medicaid revenue. So it's a relatively small share of their total mix of revenue. Now that's common. A lot of performance-based systems, you give a modest incentive, hoping it'll change the system. So, but nonetheless, it's not a lot of money that's going on. So then we try to do a pretty simple correlation. Let's look at whether you have any value-based payment system and how big your value-based payment is, and how did that correlate with your financial margins. And the information I got was sort of mixed. And again, this is really back of the envelope stuff. For the first 2 years I looked at, 2020 and 21, zero relationship. No correlation between whether you had a value-based payment system, or how much it was, and what your financial margins were. In the past 2 years, there was some relationship. There appeared to be some relationship that places that had a value-based payment system had slightly higher margins. However, oddly enough, the amount that they earned under the value-based payment system, the actual margin levels, was not correlated with their financial margins. So it's sort of a mixed story. Overall, I'd say there's no strong evidence that being in or getting, sort of participation in a value-based payment system is improving their margins. I think part of this is, once again, the amount of money they're getting from the value-based payment systems is pretty small. So it's sort of like, being in a teacup when you're in a sea that is sort of roaring up and down. Sort of the value-based payment system might give a little, might take away a little. On the other hand, if there are these larger currents of Medicaid unwinding, COVID supplemental funds going away, some of the other problems of the sort of healthcare inflation pressures, workforce shortages that health centers are facing, then it might make a little difference, but not enough in that sort of broader storm.
That's so helpful to know. And I think aligns with a lot of other literature we have on value-based payment and sort of its complicated relationship with finances and margins of, healthcare providers across the continuum. And I think highlighting sort of when there's a lot at stake in these programs, when there's a little at stake, also just sort of helps me contextualize a little bit about the conversation that we're having. So just
Paula,
want please.
can I add on a little bit of the challenges as well? So, and I think Amanda was spot on, Leighton. Thank you. Some of this stuff is actually terrifying to me, of sort of where we are and where we're headed. And I think Leighton's findings around the financial position of community health centers across this country concerns me. But I want to point out some other challenges. So one is we talked about it earlier, lack of multi-payer alignment. And that lack of alignment becomes a challenge. So value-based payment models are typically designed and implemented by payer, Medicaid, Medicare, commercial plans by contract, as we mentioned. Thus, the payment only covers and supports the applicable subset of the FQHC's patient population. That's important to remember. Because the FQHC model of care doesn't treat patients differently, that's not what we do based on their insurance type or lack thereof. It can be hard to transform care and adequately pay for it under the VPB model introduced by one payer. So if the FQHC's other payers are still volume-based, where more billable visits equal more revenue, then there are conflicting financial, clinical, and operational challenges. One additional one that I thought, Amanda, I would introduce as well, and maybe you touched on this as well, is it could take significant time for community health centers to see those savings, those dollars, up to 2 and 3 years. And we need a quicker way to get that investment back in FQHCs in the model of care. That lag time can be pretty devastating for a health center that's looking for those savings.
That's extremely helpful. Thank you so much, Michael. I'm keeping an eye on the time in my role as moderator, and I just wanted to say we're about halfway through our conversation, and at this point, I'd love to make a pivot and really open up this conversation to all of you. I think we've spent a really good amount of discussion on these myriad challenges and barriers that make it hard for health centers to participate in these models, to be able to scale up infrastructure and personnel needed to participate in these kinds of programs in value-based payment. And I would love to sort of make a shift at this point and talk about what's worked in existing value-based payment models, what hasn't worked, and sort of what can we learn a little bit from this. And so maybe I think what I'd like to do is just sort of open up the question of whether any of you have seen current value-based payment models in the health center setting where the health centers are not sort of starting from a position of financial disadvantage or other disadvantage, where they're being set up with a greater likelihood to succeed when it comes to improving quality and containing costs. And I think maybe, potentially starting with some potential, success stories, if there are any, hopefully there are, might help us sort of chart a little bit of a course forward in terms of where we think policy should go, where we think the conversations should be. So I'll leave that question open to anyone.
Maybe, Paul, I'll kick it off, just because I think we haven't really talked about what people deem to be the benefits of the adoption of value-based care as deeply as we could. So, again, Jim Hunt, my predecessor, used to say people across the country have Massachusetts-itis, right? They're sick of hearing about Massachusetts. But the reality is, we're early adopters in this VPB model, especially in Medicaid and Medicare. So 100% of eligible FQHCs agreed to participate in Mass Health, our Medicaid program, ACO program, when it launched in 2018. 100% adoption. 100% of eligible FQHCs currently participate in Mass Health's primary care subcapitation model or program. Currently a requirement for all primary care providers participating in the ACO. 10 FQHCs are participating in ACO REACH, the Medicare value-based payment program. 17 FQHCs are participating in the Medicare Shared Savings Program, which is the Medicare value-based program. 3 FQHCs are participating in Making Care Primary, again, a Medicare value-based payment program. So VPP models allow providers to focus on identifying and addressing the needs of the patient. That's what I hear both here in Massachusetts and across the country, is the whole hope of that, Amanda and Leighton, is that we can be able to lean in a different way than we were before under just a straight PPS, and not have to focus on just billable visits. So the VPP models also allow providers to lean into team-based approaches to care, where non-billable, non-revenue generating staff, such as community health workers, can be integrated in and more strongly engaged in patient care. That's the hopeful part of this work. Another benefit of value-based models is the opportunity to receive additional dollars, as we talked about, beyond the payment of services, including through pay for performance and shared savings arrangements. However, to the challenges, the calculation and distribution of these dollars can be delayed, sometimes by multiple years, and value-based payment would be more effective for FQHCs if they could receive these dollars quicker to invest back into FQHCs and their particular model of care. So just a quick thought about what we're seeing. I think it's too early to tell. As I talk to our members here, the hope is still there. Some refinements and adjustments have to be made by our state Medicaid department, but people still remain hopeful about this payment option.
Yeah, I would to just build on what Michael is saying, and you said it beautifully, so there's not a lot to add, but I think the saying in the health center space is you've seen one health center, you've seen one health center. And I think as it relates to this particular topic, their health centers are very much, everyone is in a different place in this journey. And everyone also has different capacity to engage further. And so I think generally where we've witnessed the greatest success is where we've been able to address some of the things that we were talking about earlier in terms of flexibility, in terms of upfront sort of dollars coming in and addressing that initial investment. I think, in my perfect magic wand dream world, it's working with partners of all shapes and sizes, but who basically just let health centers do their thing. The outcomes are there. The proof is there. It's mostly where we run into issues is where their hands are tied because they either don't have the resources or they don't have the flexibility to do what they need to do. And so we're starting to see models like that. I mean, I think Michael is 100% correct there. CMMI has done some really incredible work and put out some fantastic pilots, of which some were geared specifically at health centers. And we're seeing that kind of play out in positive ways. But we're also seeing that, the reality of some of these things is that you're learning constantly throughout the process. But when you engage in some of these programs and pilots and arrangements, the learning would cause you, if you had the capability, to change quite a bit. But that's not, again, it comes back to flexibility. You often can't change midstream. And so health centers find themselves in a situation where, boy, this looked really good and it worked really well for the first 18 months. But now, because of X, Y, and Z, it's actually much better if we pivot to do this. But do they have the flexibility to do that? No, often they don't. But Leighton, I don't know if you have other things that you'd add.
So I must admit, I don't know enough about this specific system. I heard people from various states saying, gee, we've been involved in VPP. It has worked well for us. Or some particular managed care program works really well. So every now and then I hear people from Oregon or California or some other state say, gee, we think it works pretty well for us. I will be honest and say, I don't know the details of these things. And so I am willing to believe what Michael and Amanda say, who are so much more in touch with these sorts of things. Now, what I will say from the data analysis we did, again, it looked as though there was a little better relationship between VBP and margins in the past couple of years than in 2020 and 2021. So maybe this means that things are getting a little better. People are being a little smarter about how to implement these systems. But again, this was such a simple-minded analysis that I did that we can't get into those things. I'd love to be able to try to do some more refined analysis. And maybe if some funder has some money, they'd like to help us do this. But we can look at it a little more. But for sure, there are reasons to think that VBP can be useful. Again, some of the things that Amanda and Michael talked about, the ability that they might give some upfront money to help pay for some of the technological innovations they need to make, can really help. On the other hand, once again, there's There are other forces that are making it tougher for health centers. So it's not all just the payment systems. They might make a little bit of a difference, but we have this broader context of what's happening in a big picture in Medicaid, what's happening in a big picture in Congress and the 330 grants and so on and so forth. So it's a complicated world.
This is such a helpful way to think about sort of if we know that value-based payment is somewhat here to stay in terms of the way that we think about reimbursement in our healthcare system, are there certain challenges that we can link to different features of payment programs? And so I know we've mentioned upfront investment, which I know is part of some models, but not others. Amanda, you mentioned sort of the need for flexibility, and it reminds me of whether, I know some VBP models have on ramps and off ramps, and sort of whether there's a way to incorporate this pivot potential in a way that is transparent and beneficial for the health centers also somewhat comes to mind. And then I just want to say thank you all so much for the questions that are coming up in the chat. I'm going to try and weave them through here, but please forgive me if I can't get to them. One of the comments mentioned sort of ways for us to think about high-risk patient pools and whether there are different ways for us to think about performance and measurement. And I think that brings me to my next question, which, I think is something that has come up a little bit throughout our conversation today, which is sort of how are we currently thinking about quality and performance in health centers? Do you find that the current measures that we're using are relevant, salient? If you could change them, what would you change them to? I think this is such an important part of the VBP conversation, yet is something that I think is, of course, complicated with multiple stakeholders, but would just be helpful to sort of hear your thoughts on the relevance of current quality performance measures and where you think they should go in the future.
I'll start, and then I suspect Michael and Leighton will want to chime in. I think the measures that we have are certainly useful. There's no doubt, especially because it's data, right? You're looking at outcomes, and so yes, the quality measures are there. But I think that we have a lot of work to do to capture some of what we were talking about earlier. That just there's no real way to track and account for both the cost, but the outcomes. So when you look across all of the social drivers, to me, and I will also kind of out myself, maybe this exists in a way that I just haven't seen yet, or I'm not enlightened to, but when you look at I'm sorry, because I'm thinking out loud, but Prepare being a great example of like, this is an effort at getting at some of these things, and it's been really meaningful and impactful. However, there are still areas where how do you capture the work of a CHW who, one, isn't billable, but also like they're having conversations about things that have a direct impact on that person's choice and decision on a litany of other clinical indications that we can track. But those are the things where that's what I mean about we have a long way to go. There's just, and I don't know the answer to that. To be honest with you, I'm not sure. I think the smartest people in the country have put a lot of time, energy, and thought into trying to figure out how to capture it, but we're not there yet. But I also don't think that we should discard the work that we've done and the quality metrics that we have. I think that serves as a great foundation, but there's a lot of work to do to build out.
And I would absolutely agree with Amanda. The only other thing I would add, and ditto to everything Amanda said, would be just the conversations here in Massachusetts. We were adopting value-based care and payment was around risk adjustment for social determinants. So the VPP models have to include risk adjustment for social determinants of health and behavioral health factors that FQHC's patients experience. We know that we're dealing with high acuity, right? We know that we're dealing with patient populations that are disproportionately impacted by the myriad of social determinants of health. So for example, it wouldn't be fair to expect a federally qualified health center to impact diabetes or hypertension outcomes over the same time period without additional resources for patients who are homeless and have severe or persistent mental illness, or patients without these co-occurring conditions. So that nuance of the conversation about what is the patient populations we serve, it's important not to use historical utilization or base rates on previous fee-for-service experiences. If they are, then payment rates need to be adequately adjusted to account for underutilization in primary care, as well as frequently changing FQHC patient populations. So it's a rabbit hole that I'm going down, but it's one that I think is really important that we think about risk adjustment for social determinants of health and behavioral health factors. We know if you are at Boston Healthcare for the homeless, as Amanda said, this is a different conversation than if you're at another health center. The patient population, the challenges of those patients have to be part of the conversation and part of the assessment of quality.
So I would just, sorry, Leighton, I was just going to say there's a similarity here, and you know, all three of us, I think probably many on the call, we work in the policy space, and where this is policy. But when I think about politics and Congress and any, you know, state legislatures, doesn't matter. The challenge with this, right, is that it requires a scalpeled approach. It's so different each and every time. However, the system, whether it's in politics and policy in that respect or the conversation we're having, it's a sledgehammer, you know, and that doesn't work. That's why we keep, you know, running into these same issues. And so I have some optimism. This is one space where, you know, a little early to tell, but perhaps with AI and some of the technology that's emerging in terms of being able to very quickly look at all of the differences across what we're talking about and then come up with something that's useful to address that scalpeled approach. I don't think we're there yet, but I think hopefully there's opportunity. But Leighton, please, I cut you off. Apologies.
Oh, no. One of the things I wanted to bring up that Michael made a point of that I think is important to think of, again, it's because the fragmentation of the healthcare system is multi-payer alignment. Again, what health centers, and this is not just health centers, doctors, hospitals all complain about, we're using different performance indicators, we're using different payment incentives. If there can be some alignment across multiple payers, then you'd have a consistent signal that's saying these are the things we think you'll be rewarded for. That's tough to do right now. That's hard to do for health centers, but not, you know, it's not impossible. Some states are trying this, CMS has tried this in some areas. The other thing that I'd like to reinforce what sort of Michael and Amanda were both saying is there's certain things that health centers do that are not part of the sort of regular primary care mix. So it's important to measure how you're doing with your diabetic patients, how you're doing with control of hypertension. On the other hand, there are issues like behavioral health care. There are things like this sort of enabling and social services that are so critical to health centers, things like the use of community health workers to go out in the community. And those aren't being captured at all, but are clearly part of the secret sauce of why health centers have been successful. And so it'd be useful to think, are there some ways to think about measures like that, again, that are not horribly burdensome to collect, but that might actually then give health centers the belief that, yes, we'd like to encourage more of these things too.
It's interesting to sort of try and strike this balance that I think, Leighton, you mentioned of not wanting to overburden the quality reporting needs, right? Because goodness knows we have far too many quality measures out there, but really just sort of, you know, trying to use Amanda's approach of like a scalpel to really like identify what the important salient quality measures should be, so that you can sort of tailor resource allocation and payment toward incentivizing the things that either A, health centers perhaps already are doing but are not being recognized and paid for, or B, helping health centers sort of make the investments needed, whether it's people or personnel, to sort of achieve those goals. I'm with our last 11 minutes, I'm gonna have two more questions, if that's okay. My first question is to sort of zoom out just a little bit, not 30,000 feet, but maybe like 15,000 feet, and say, like, if we were to put our policy hats on with like a big P policy, are there certain policy endeavors that you think would be big ticket items for us to think about right now, that would sort of help health centers, you know, thrive not only in their current functions, but also thrive potentially in this environment of value-based payments? Some of the themes that I've heard in this conversation are the need to consider updating PPS, or perhaps shifting from PPS toward other payment approaches. Should we be having conversations about, you know, the way we think about high-risk patient populations? What should we think about from workforce and scope of practice laws? I'm just curious, sort of at this like 15,000 foot view. The next one will be 30,000, of course. But, you know, it's sort of thinking about our existing policy conversations, sort of what kinds of conversations do you think we should be dedicating our attention to?
I'm willing to make a stab. So probably the most important policy thing I'd say is health centers need some sort of stable source of funding at that core funding for that Section 330 funding. And so here, the critical concept of what's called in Congress is mandatory funding for health centers. There's mandatory funding that was brought in under the Affordable Care Act. It expires in December. we need to have a multi-year reauthorization of mandatory funding with enough funding in there that can basically tell health centers, A, there's some stability. We know you're going to be guaranteed. You can make plans for the future. You don't need to worry, how will I be paying my staff in January? That in addition to this, does permit some growth. And again, I know money is tight and Congress is likely to be tight, but we know that health centers save money. So that's the crazy thing. If we give more of an investment in health centers, it does pay off in the end. And so again, CBO acknowledged this. So, this is to me a no-brainer.
And the only thing I add to what Leighton just said is it's not just the federal agencies that have recognized that health centers save money. Even on state levels, like here in Massachusetts, our agencies have identified that health centers save money. So I'll often, in conversations, I'll be testifying at our Health Policy Commission in about a week late. And I always say, pay now or pay greater later, right? So you can invest in primary care. You can invest in community health center model of care, because we know we keep patients out of the emergency room, we keep them healthier, we keep them on their jobs so that they're able to still to function and to live healthy lives. Or you cannot do that. You cannot invest in our model of care. And those patient populations, we see health inequities, disparities increase. We see communities at higher morbidity, mortality rates. We all ultimately, both literally and figuratively, end up paying for it. Right? I can give you dollar figures around health inequity in Massachusetts, $5.9 billion a year that we've estimated that is the cost of inequity in Massachusetts. We are on the front lines of addressing that inequity because we're serving those patients. So if we invest, Leighton, like Leighton said, in what we know works, the system would be much more impactful, and we'd save money, we save lives. But unfortunately, I am always beating the drum, as Amanda and Leighton are, that we don't put our money where our mouth is.
Yeah, so we're all singing the same tune. I definitely, everything that Michael just said, everything that Leighton just said, I think that health centers are the safety net for our country, for everyone, and they need a safety net to ensure they can continue to do the work. I also think, I am not going to comment on what is to be in the next administration, but I think that health centers exist as a solution to all of the things that we're talking about. And so a concerted investment beyond just creating a safety net for them, but actually leaning into all of the things that we've been talking about through health centers, sort of not just keep us whole, not just create the safety net, but actually build out the program further in order to create and build on the innovations. But I think, something else that's just, again, sort of that 15,000 foot level, I think something I was just going to say as simple as, this is not simple, but at least for the government programs, quicker access and more consistent access to data and claims, something even that would help considerably. And so there are things that we could detangle in the short term that would have quite an impact. I know this came up in a couple of the questions. There are other programs, since we're talking sort of, we need funding. 340B program is another one where, like, if we can get that taken care of, at least for health centers, because of the vitality of that program for health centers in order to be able to carry out the work and their mission, I'm not going to minimize how big a deal that is, but that's another program that's very front and center that, with the correct supports and framework to support health centers in leveraging that program effectively in exchange for accountability and transparency. We don't need to get into the details of it, but that would be a massive, not just support or continued support for health centers, but it would enable a lot more progress and momentum, I think, on what we're talking about in the bigger space of how do we move in the more integrated direction of value-based care and contracting.
And just, Paula, really quick, I'd be remiss if I didn't do this as I was preparing with the team around what I wanted to cover. We have phenomenal government affairs and public policy team here in Massachusetts. And one of our, Amanda, I don't know if you've met her, one of our phenomenal folks who works for Caitlin McColgan, who just left us recently, is Christine Piper. She said, Michael, don't forget, we need to, big P policy suggestion is payment models that help shift the proportion of spend to primary care and preventative care. If I did not say that, I'd be disappointed if I got off this call. So Kristen, I did get it in. it is important that we do a shift in how we prioritize preventive and primary care.
Thank you so much. We are coming down to our last few minutes of this conversation. I've so enjoyed learning from all of you about health centers, the complicated financial world in which they live in, sort of where value-based payment tries to fit into this complicated landscape, and sort of how we can think about optimizing those models for the mission that health centers are providing daily. And I thank you for these like really wonderful and I think targeted policy interventions for us to think about as we move forward. In my last question for you all, I'm going to do the 30,000 foot thing, and I'm just going to ask you to take sort of a pie in the sky policy intervention that, you know, if you could start from scratch really and create a payment system for health centers that would support them in their mission of serving structurally marginalized patient populations in achieving population health equity because they are at the front line of this. What would that be? What would your pie in the sky sort of idea be? I know it's there's only 3 minutes left, but perhaps if we could just go around and just talk about that. I might pick on you all for this one. Leighton, if you wouldn't mind kicking us off.
Oh, gee, I don't know. I actually think the sort of the underlying concept of the prospective payment system was not a bad idea. Part of the challenge has been what Michael and Amanda were talking about, which is it hasn't kept pace with reality. It hasn't been updated because of the actual change in cost or because of the change in the scope of services that health centers do. I think if we could sort of go back and we might redesign how that performance-based system works, but you know, at the very least, if we could sort of make sure that really sort of gets updated and stays true to meeting that purpose so that you're adapting to meet the cost of the health centers. Again, there's a pretty strong system that already exists, and it's largely coming from HRSA that tries to monitor the performance of health systems, encourages them to do well on various measures. You know, it's a system that's already correcting itself. It's not under the VBP mandate rubric that we think of in Medicaid and so on and so forth, but it's worked remarkably well.
Thank you so much. Michael, I might turn to you next.
Yeah, I think when we've said it before, the comprehensive services that FQHCs provide, right? So we need to have the payment that allows for those comprehensive services bundled prospective payments. We often have to advocate for the infrastructure to build and advance the capabilities of community health centers to meet all the expectations that we have, such as now an increased awareness around addressing health equity or providing additional and new services, and that upfront payment is going to be critical. Achieving performance metrics that are selected to meet the needs of different populations. Transition remaining fee-for-service payments to population-based capitated payments over time. Probably in my closing, I'd say that the model should also allow FQHCs to share in the savings that are generated in a total cost of care and to continue to evolve their value-based models. We need time with this. We need to make sure that the investments are there. I will just say this as a cautionary note across the country. Most state agencies, many state agencies, don't even understand a PPS system. So what was done in Massachusetts, we sort of held the train up until we educated ourselves and our regulatory agencies. What is PPS? And that needs to be the foundation of this model.
Thank you so much. And then Amanda.
Well, the good news is that my team and I discussed this, and ours is or what we came up with, it's pretty concise. And it is, you know, again, probably magic wand, which is a world I like to live in sometimes. It would be to provide quarterly advance payments for Medicare, Medicaid, and commercial based on historic claims data with a single set of quality measures aligned with UDS. So, you know, just not a tall order at all, just, you know, throwing it out there.
I love it. And I think what a wonderful note to sort of close our conversation on. I want to say thank you so much to Amanda, Leighton, and Michael for this conversation today. I certainly have learned so much and feel that I can think about sort of policy directions moving forward. We're so grateful for your time. This is also part, we at LDI have been working with the Independence Blue Cross Foundation on some work with health centers. And so it's just been really helpful to hear sort of what the national experience has been and sort of lessons that we can take back to Philadelphia. With that, I'll turn it over to Rachel.
Great, thank you. I want to echo Paula's thanks to all of our panelists for the great conversation today. I really also learned a lot, and I appreciate you spending the time with us today. And Paula, thank you for the moderation. Uh, Excellently done. Thanks to the audience who tuned in today. And as Paula said, thanks to the Independence Blue Cross Foundation, who helped support some work in this area. And we will be issuing a policy brief based on this topic in the coming weeks. Stay tuned. The next event will be integrated care for dually eligible beneficiaries, which will take place on December 6th here on Zoom, and we hope to see you there. Thanks, everyone.